your teeth are touching, or hovering millimeters apart under muscular tension you have not noticed once today. The masseter, the strongest muscle in your body relative to its size, capable of generating 70 to 100 kilograms of force during a deliberate clench, has been holding 3 to 8% of its maximum contraction since you sat down this morning. 2 to 5 kilograms of compressive force through the temporomandibular joint on each side of your skull. Continuous. The contraction was never requested, and you did not decide to clench. The muscle is responding to a sympathetic signal that has been arriving for hours. The low-grade fight-or-flight activation that modern life sustains through work pressure, screen concentration, deadlines, and commute stress, keeping the jaw braced as part of a protective response the body never fully resolves. At rest, the masseter should be electrically silent. Zero contraction, teeth slightly apart, the mandible hanging from its own weight. Surface electromyography in adults over 45 shows the masseter is almost never fully silent during waking hours, as Glaros and colleagues documented in the Journal of Behavioral Medicine. That sustained low-level contraction, too low to feel, too high to be harmless, running across every waking hour. Running across every waking hour. The headache that arrives at 4 in the afternoon, behind the eyes, across the temples, a band of pressure tightening from the base of the skull toward the forehead, did not start in the head. It started in this muscle at 8 in the morning, beneath awareness, and it has been building a cascade upward through your skull along a specific cranial nerve ever since. Masseter originates at the zygomatic arch and inserts at the mandibular angle and ramus, a short, thick muscle designed for brief bursts of high force during chewing. Each chewing cycle lasts roughly half a second. The masseter fires, produces force, and returns to electrical silence. Design duty cycle, active for meals, silent between them. The temporalis, the fan-shaped muscle covering the temporal bone on each side of your skull, co-contracts with the masseter during jaw closure and adds lateral stabilization. When the masseter holds chronic tone, the temporalis holds chronic tone alongside it. Two muscles covering the sides of your skull from the jaw angle to above the ear, contracting continuously at low level for every waking hour. Put the scale of this in perspective. The masseter generates more force per unit mass than any other muscle in the body, a muscle the size of your thumb producing forces that exceed what your quadriceps generates relative to its cross-sectional area. The evolutionary purpose was clear. Our ancestors needed powerful, brief jaw contractions to process tough, fibrous food. The modern diet requires a fraction of that force. The muscle that evolved for intermittent high-force chewing is now being driven at continuous low-force contraction by a nervous system responding to psychological stress rather than mechanical demand. The mismatch is profound. A muscle designed to fire and release, held in permanent low-grade contraction by a signal that has nothing to do with food and everything to do with the ambient threat level your nervous system perceives in an email inbox, a traffic jam, and a news feed. That compressive force, sustained across waking hours, falls on the cartilaginous disc inside the temporomandibular joint, the hinge where your mandible meets the temporal bone. The disc, designed for intermittent loading during meals, receives sustained compression it was not built to endure. If your jaw clicks, pops, or aches when you open wide, when you yawn, when you bite into an apple, when you wake in the morning with stiffness along the jawline, the disc is deforming under loads that should have been transient. The clicking is the disc displacing under compression and snapping back into position, the sound of mechanical failure at a joint being loaded continuously for a task that should occupy 20 minutes per day. The popping you hear when you open your mouth wide in the morning is the disc that spent the night compressed, finally repositioning under the reduced load of the open jaw position. Temporomandibular disc, like cartilage elsewhere in the body, depends on cyclical loading for its nutrition, compression and release pumping fluid through the matrix. Sustained compression without release prevents the fluid exchange the disc requires. The disc that receives intermittent high-force loading during meals stays healthy. The compression phases pump fluid in, the release phases allow diffusion, the disc maintains its shape, its resilience, and its capacity to cushion. The disc that receives continuous low-force compression from a clenching masseter receives neither the magnitude of loading that drives significant fluid exchange nor the release phases that allow recovery. It is compressed enough to deform, but not enough to feed, held in a loading zone that is the worst of both conditions. Over decades, the disc thins, loses its capacity to cushion the joint, and the clicking becomes crepitus, the rough grinding sound of bone approximating bone through a disc that has lost its structural integrity. The jaw pain that accompanies crepitus is mechanical failure of a disc that was loaded wrong for 30 years. Well, the trigeminal nerve, because the jaw's chronic contraction does not stay in the jaw. It travels upward through the largest sensory nerve in the face. Trigeminal is the fifth cranial nerve, 3 branches dividing the sensory territory of the entire face. Ophthalmic branch covering the forehead and eyes, maxillary branch covering the midface, and mandibular branch covering the jaw and lower face. All 3 converge in the trigeminal nucleus in the brainstem. The convergence principle, the smiling discussion described for cranial nerve 7 operating here through cranial nerve 5, where signals from different facial territories share a single processing structure. The nucleus that processes jaw sensation also processes forehead sensation, temple sensation, and sensation from behind the eyes. 3 territories that feel like separate organs, but are wired through one central processor. Chronic masseter contraction produces continuous afferent input through the mandibular branch. Trigeminal nucleus receives this sustained signal and undergoes central sensitization, a measurable decrease in the threshold for pain signaling, as Svensson and Graven-Nielsen established in the Journal of Orofacial Pain. At normal sensitivity, the nucleus would process the masseter's low-level input without generating pain. The signal is too weak, the contraction too mild. But hours of continuous input ratchet the sensitivity upward until stimuli that would not normally produce pain begin producing pain. The nucleus becomes hyperexcitable, responding to the normal pulsation of temporal arteries, the gentle pressure of spectacle frames on the bridge of the nose, the warmth of sunlight on the forehead. The headache feels disproportionate to its cause because the nucleus is amplifying an entire sensory field, not relaying a single signal, and the amplification persists for hours after the jaw input that produced it. Ophthalmic branch shares that nucleus. Sensitized nucleus now amplifies signals arriving from your forehead, your temples, and behind your eyes. Territories served by a different branch but processed by a single central structure. You feel pressure behind your eyes, tightness across your forehead, aching at the temples, and the pain is real. The source is not where the pain is felt. It is the trigeminal nucleus, amplifying normal sensation from the upper face into pain. The brain interprets as headache. Now, the suboccipitals, because the jaw's neural overflow does not stop at the temples. It recruits muscles beneath the skull that you have never heard of. 4 small muscles connect the base of your skull to the first 2 cervical vertebrae, the suboccipital group controlling fine head positioning with a precision no larger muscle can match. Convergence of trigeminal and cervical afferents in the upper spinal cord was mapped by Barchin-Goadsby in brain, a structure called the trigeminocervical nucleus where jaw signals and neck signals share the same neural pool. When the trigeminal nucleus is sensitized by chronic jaw tension, the cervical motor neurons in this shared pool increase their firing rate. Your suboccipitals contract, because the jaw's neural overflow is recruiting them through a brainstem pathway that connects territories you would never associate. Suboccipitals, when chronically contracted, compress the greater occipital nerve, a sensory nerve exiting between the atlas and axis vertebrae, traveling upward over the back of the skull to the crown. Compression of this nerve produces a band of pain from the base of the skull over the crown to behind the eyes. Occipital neuralgia, as Bogduck described in Headache, mapping the anatomy with a precision that connected cervicogenic headache to specific nerve compression pathways for the first time. If you feel headache starting at the back of your skull and spreading forward, a pattern distinct from the temple headache the trigeminal produces, you may be experiencing occipital nerve compression driven by suboccipital contraction, driven by trigeminal sensitization, driven by a jaw that has been clenching since morning. Every structure in the chain was recruited by the one below it. None of them chose to contract, and none of them will release until the first link, the masseter, receives the signal to let go. You now know the pathway from jaw to temples through the trigeminal and from jaw to skull base through the suboccipitals. The question changes from where the cascade reaches next to how far down the body a single jaw muscle can send its signal. And then, the cervical spine, because the suboccipital contraction reshapes your posture from the top of the spine downward. Suboccipital contraction pulls the occiput posteriorly, tilting the head into slight extension at the uppermost cervical segments. Your body compensates by increasing flexion in the lower cervical spine to keep the eyes level. The result, upper cervical extension combined with lower cervical flexion, the forward head posture you attribute to screen work, but that suboccipital tension is actively reinforcing from above. The jaw is reinforcing the posture the screen initiated, through a pathway no ergonomic adjustment can address. Cervical facet joints, the small synovial joints connecting each vertebra to the next, compress on their posterior aspect under the extension posture at the first and second cervical vertebrae. The compression is sustained because the suboccipital contraction is sustained because the jaw tension is sustained. A chain of mechanical cause and effect linking a muscle in the jaw to a joint in the neck through a brainstem nucleus that connects them. Cervical facet. Pain refers to the shoulder, the upper trapezius, and the interscapular region. As Fernandez de las Peñas and colleagues traced encephalalgia, mapping the referral patterns from the trigeminocervical nucleus through the cervical spine to the shoulder girdle with a specificity that explained why jaw patients present with neck symptoms and neck patients present with jaw symptoms. If you carry tension between your shoulder blades, the ache that arrives by mid-afternoon, the tightness you attribute to sitting, the knots a massage therapist finds in the upper trapezius week after week without lasting resolution, you may be carrying referred pain from cervical facets loaded by suboccipital contraction that began in a jaw you cannot feel clenching. Upper trapezius co-contracts with the suboccipitals through shared cervical innervation. The accessory nerve and the cervical plexus supply both muscle groups. The shoulder elevation you notice by mid-afternoon, shoulders creeping toward the ears, the conscious effort to pull them back down, the return to elevation within minutes despite the correction, is muscular recruitment cascading from the jaw through the trigeminocervical nucleus to the upper trapezius through shared motor pools. Your jaw is raising them for you through a neural pathway that operates entirely below conscious awareness. Massage that temporarily releases the trapezius addresses the downstream muscle. The jaw release addresses the upstream signal that contracted it, which is why the tension returns within hours and why identical knots appear in identical locations every session. The downstream muscle keeps recontracting because the upstream signal never stopped. You have been treating the symptom at the wrong end of the nerve, and the nerve runs from the mandibular angle through the brainstem to the cervical spine, and every postural muscle the shared motor pool recruits along the way. Postural cascade extends further. Elevated shoulders shift the center of gravity of the upper body forward. The thoracic spine flexes to accommodate. The lumbar spine compensates with increased lordosis to keep the head over the pelvis. A massage therapist working on your lower back at the end of the day may be addressing pain that originated in your jaw 12 hours earlier, transmitted through the trigeminocervical nucleus to the suboccipitals, through the suboccipitals to the cervical spine, through the cervical posture to the thoracic curve, and through the thoracic curve to the lumbar compensation. The jaw is the first domino. The lower back may be the last. And nobody connects them, because the distance between the mandible and the lumbar spine seems too vast for a single muscle's contraction to traverse, until you trace the neural pathway that connects them through a shared brainstem nucleus and 6 levels of postural compensation. Breathing changes when the jaw releases, and the change reveals how deeply the clenching was affecting respiration. A clenched jaw restricts mandibular depression, which limits the mouth's contribution to respiratory airflow during exertion. More consequentially, the sustained masseter and temporalis contraction increases tension in the suprahyoid muscles, the muscles connecting the jaw to the hyoid bone above the larynx. Hyoid tension restricts laryngeal descent during deep inhalation, limiting the volume of air the diaphragm can draw in. The shallow breathing pattern that many adults over 55 attribute to deconditioning or aging is partly a mechanical restriction imposed by a jaw that will not release. The airway physically narrowed by muscular tension cascading from the masseter through the suprahyoid chain to the structures that govern how deeply you can inhale. Release the jaw, and the first full breath afterward feels measurably deeper, because the mechanical restriction on the airway released. My teeth separate several times an hour now, a conscious interruption that turned automatic after 3 weeks of practice. The jaw was clenching in every meeting, every commute, every evening on the sofa, and the connection to the afternoon headache only emerged when the release consistently eliminated it, not reduced it, eliminated it. Nocturnal bruxism extends the cascade into sleep. Teeth grinding generates forces of 40 to 70 kilograms, 10 to 20 times the daytime resting contraction, in bursts repeating throughout the night. The trigeminal nucleus that was sensitized by daytime contraction receives amplified input overnight. By morning, the nucleus is maximally sensitized, and the headache that seems to arrive with the first hour of screen work was loaded during sleep. Morning jaw stiffness, morning headache, tooth sensitivity that dental examination cannot explain, all consistent with a jaw that spent the night generating forces the temporomandibular disc was never designed to sustain. Bruxism also fragments sleep architecture. Chronic masseter contraction activates the brainstem's arousal network, sending a signal during lighter sleep stages that prevents descent into the deep, slow-wave sleep tissue repair requires. If you sleep 7 hours and wake exhausted. If you have been told your sleep architecture is normal, you may be experiencing arousal fragmentation driven by jaw tension, no standard sleep assessment monitors. A dental night guard distributes bruxism forces across a broader surface, reducing peak pressure on the disc and teeth. But it does not stop the contraction. Addressing the daytime clenching through conscious release practice reduces the sympathetic tone driving both daytime contraction and nocturnal bruxism. The guard protects the teeth and the disc. The awareness addresses the source. Now, why this accelerates after 45? Because 3 age-related changes converge in the jaw, the way they converge in every system this series has examined. Sympathetic baseline rises with age. Chronic low-grade sympathetic activation. From accumulated stress patterns, sleep disruption, inflammatory burden, and autonomic dysregulation, keeps the masseter contraction signal elevated for more hours per day with each decade. The jaw that clenched during work stress at 30 now clenches during driving, reading, watching television, and lying in bed before sleep at 60. The contraction window has widened, while the recovery window has narrowed, and the temporomandibular disc, the trigeminal nucleus, and the suboccipital muscles are absorbing the consequences of a duty cycle that has expanded from 8 hours to 16 without any corresponding increase in the recovery time between contraction episodes. Dental changes compound the mechanical problem. Tooth loss, wear, and decades of dental work alter the occlusal surface, the contact pattern between upper and lower teeth. The masseter adjusts its contraction pattern to accommodate the changed bite. Asymmetric tooth wear produces asymmetric masseter contraction, which produces asymmetric trigeminal input, which produces one-sided headache you may have been told is migraine. The laterality of the headache matches the laterality of the dental asymmetry, a connection rarely made in clinical practice because the headache specialist and the dentist occupy different buildings and neither one asks about the other's territory. Suboccipital muscles lose compliance with age. Chronic contraction produces fibrotic changes in the muscle tissue, collagen infiltration replacing contractile fibers, reducing the muscle's ability to fully relax even when the neural drive decreases. The muscles become structurally shortened. The occipital nerve compression becomes structural rather than purely functional. The headache becomes chronic rather than episodic. Medications common after 55 compound. The jaw tension through mechanisms most prescribers do not connect to the headache. Selective serotonin reuptake inhibitors, among the most widely prescribed medications in this age group, increase bruxism as a documented side effect, intensifying both the daytime clenching and the nocturnal grinding. Stimulant medications, decongestants, and even moderate caffeine intake elevate sympathetic tone, increasing the baseline masseter contraction the nervous system sustains. If you started a medication and noticed an increase in jaw tension, morning headaches, or tooth sensitivity within weeks, the medication may have increased the masseter's contraction level through sympathetic or serotonergic pathways the prescriber did not anticipate. This is a reason to discuss jaw symptoms with the prescriber, not a reason to stop the medication. Muscles that should release the tension have lost the physical capacity to do so without deliberate intervention. And then, the release, because what happens in the first 60 seconds when the jaw finally lets go follows the cascade in reverse. Moment you become aware of the masseter contraction, the moment you notice the teeth are touching or the jaw is braced, the cortical override begins. Conscious awareness of an unconscious contraction allows the motor cortex to inhibit the signal the sympathetic system has been sending. This is the only point in the cascade where voluntary control is possible. Every structure above the masseter contracted involuntarily through shared motor pools and postural compensation. Only the masseter itself responds to conscious inhibition. The teeth separate. The masseter drops from 3 to 8% contraction toward electrical silence, the resting state the muscle was designed for and has not occupied during waking hours in years. The temporalis follows within several seconds. As the masseter releases, trigeminal afferent input decreases. The sensitized nucleus begins recalibrating. The threshold for pain signaling rises back toward normal. The amplified signals from your forehead and temples gradually diminish. The headache that has been building since morning begins thinning from the source, not from the periphery inward, but from the nucleus outward, as the sensitization that amplified the pain resolves at the brainstem level where it was produced. Trigeminal input drops and the suboccipital muscles begin releasing their co-contraction. The neural overflow from the trigeminocervical pool diminishing as the jaw's contribution falls. The greater occipital nerve decompresses. The band of tension from the base of your skull toward the crown loosens. The upper trapezius drops. Your shoulders descend, not because you pulled them down, but because the recruitment signal from the jaw stopped arriving. The cervical facets unload as the upper cervical extension resolves. The forward head posture that you held for 8 hours eases without effort. The first full breath after the jaw released made the practice permanent, measurably deeper without effort. The airway restriction I had been attributing to age lifting in a single exhale. The suprahyoid chain that the clenching had been tightening for hours released, the larynx descended, and the inhale that followed was the deepest breath of the day. That breath is why the hourly check is no longer optional. The release, the ground rest discussion described for the suboccipitals, gravitational decompression through firm surface contact, operates from the outside. This release operates from the inside, removing the neural drive that contracted the muscles in the first place. Both arrive at the same destination through different physics. The gravitational method requires a surface. The jaw release requires only awareness. Practice is specific. Lips together, teeth apart, the resting position the masseter was designed for. The tongue rests against the palate behind the upper front teeth, which reflexively inhibits masseter contraction through a neural circuit linking tongue position to jaw muscle tone. This is not a relaxation technique. It is a motor cortex override of a sympathetic signal, the conscious mind interrupting a reflex loop that the unconscious nervous system has been running without permission for hours. Set a reminder every hour for the first week. When the reminder arrives, check. Are the teeth touching? In most cases, they will be. Separate them and place the tongue against the palate. Hold for 10 seconds, long enough for the masseter to register the new position and the temporalis to follow. The 10-second hold is the retraining signal, the motor cortex overriding the sympathetic drive and establishing a new resting default. By the second week, the checks run automatically, a proprioceptive sensitivity to jaw position that develops through repeated conscious interruption of the unconscious contraction. You begin noticing the teeth touching without the reminder, the way you notice a slouch after weeks of postural awareness. By the third week, the default resting position begins shifting, the masseter spending more minutes per hour at genuine electrical silence rather than low-level contraction. The trigeminal input decreases proportionally. The afternoon headache arrives later, arrives milder, and eventually stops arriving. Not because you treated the headache, but because you addressed the contraction that was sensitizing the nucleus that was producing it. Headache diary is the objective measure. Track the time the headache arrives, its location, and its intensity. Compare the first week, before conscious jaw release, to the fourth week, to the fourth week, to the fourth week. The pattern the diary reveals is the pattern the cascade predicts. Headache onset delays as daytime clenching decreases, intensity drops as trigeminal sensitization resolves, and location shifts from bilateral temples toward resolution. For anyone with active temporal mandibular joint disorder, diagnosed trigeminal neuralgia, or recent dental surgery, discuss jaw release techniques with your physician or dentist before beginning. The mechanical relationships described operate through identical pathways that clinical conditions affect, and the approach should be coordinated with existing treatment. Long-term protocol is integration, not exercise. The jaw release is a continuous awareness practice woven into the hours the clenching occupies. Every hour, the teeth separate. Every transition, from driving to walking, from screen to conversation, from standing to sitting, becomes a jaw check. The transitions are the moments sympathetic tone shifts and the masseter re-engages. Catching the re-engagement at the transition prevents the cascade from building the momentum that produces the 4 o'clock headache. The practice is about interrupting a neural loop at its source before the downstream structures are recruited. Within a month of consistent practice, the default resting position of the jaw shifts measurably. The masseter spending more of each hour at genuine electrical silence, the trigeminal input dropping proportionally, the afternoon headache arriving later and milder until it stops arriving at all. 60 seconds. The timeline varies by individual. The longer the clenching has been sustained, the longer the cascade takes to unwind. Decades of fibrotic change in the suboccipitals will not reverse in a minute, but the direction is consistent and immediate. The jaw releases, the trigeminal input drops, and every structure recruited upstream releases in sequence. The headache that survived ibuprofen, massage, and eye exercises diminishes when the jaw lets go, because the headache traced back to a single muscle that was never asked to stop contracting. The teeth separate. The jaw, the muscle that held 3 to 8% of its maximum contraction for every waking hour of every day, goes silent. It was waiting to be told that it could finally stop. The telling takes 1 second. 1 second to interrupt a cascade that has been building silently for 16 hours.